boosting women participation in digital health. And at this particular moment, I'd like to invite the moderator of this session, a wonderful lady. She is the Global Director, Advocacy and External Engagement at Pathfinder International. Please help me welcome Ruth Ngeshu. Pigeni makofi tafadhali. Ruth, you wanna come up, please? Let me help you. Are you okay? Comfortable? It's a little bit, this staircase, they can do wonders, okay? So I'll be here, Ruth. For all the ladies coming up, I'll be helping them up, yeah? Because I took lunch, hallelujah. But at this particular moment, I'll hand over this particular session to Ruth. Enjoy.
Good afternoon. Good afternoon. Are we happy? Just after having a very heavy lunch. This is not the best time, I know, but we'll make it very interesting. I am here to work or to discuss with a very interesting, very enlightening team who are in the digital space. They are ladies and one man. I was wondering why the man is here, but he will explain. The context of this particular session is to help us understand why it is important we involve ladies and women in the digital space. Digital health is evolving. There are many opportunities, particularly those affecting women and girls. Digital health is not gendered. We don't have technologies or initiatives that are biased towards any gender. However, we know that gender-related disparities in access, usage, and impacts do exist, and therefore we need to make sure that we are considering gender for equitable health outcomes. I am well informed that in this room, 60% of the participants are ladies. I want to congratulate the organizers. I was very worried when we started because the first panel had, I think, 4 men against 1 lady. So I was determined if the trend continues, I will throw the only man in the panel. But now, given that we have so many of our ladies, I will appreciate that you have a male ally. So I will not take a lot of our time. I want to invite the panel to come on stage. I will start with Dr. Margaret. Please join us on stage. Dr. Margaret is the CEO of PS Kenya with experience as the CEO. She has a very impressive career that includes leading teams to deliver multiple large strategic programs. She was, I think, the first to bring about or to be the local leader for PS Kenya. While I was having lunch with her, we were talking about the localization agenda. I hope it will also feature as we talk about digital health. Next on stage, I want to invite Kanishka, Chief Digital Health Officer, Living Goods. The only man to offer security on this stage. He has 20 years of experience breeding strategic thought leadership, technology foundation, understanding of government. He has actually supported 23 countries in spearheading and designing development, deployment of innovative digital solutions. Welcome. We have somebody joining us virtually, Dr. Ezina. Can you hear us, Dr. Ezina?
Yes, I can hear you. Good afternoon, everyone.
Afternoon, thank you for joining us. Dr. Ezina is digital health strategist. She has been a leader for many years, has international experience in leadership. She has integrated clinical expertise with data-driven solutions, and she has great track record in transforming healthcare through digital health, spearheading preventive healthcare, vaccination, epidemiology, and supply chain high-value programs across the region that is in Africa. Next on stage, we have Rita Okuthe. Please join us on stage. She's executive chef for CarePay, /Mtiba, Karibu Sana. Seasoned professional with 25 years of experience in governance, technology investment, money matters in technology and health, successfully implemented organizational reforms, and digitized service delivery for public sector and small and medium enterprise. Just to make sure, we were to have Dr. Nola. I don't know whether she's here or her representative. Thank you very much. So help me appreciate our panelists as we join them on stage. Thank you very much. So I'll start with you, Margaret. First, why are you here?
I'm a woman and really excited to be a role model to other women, for them to know that indeed it is possible to speak in a room and be respected by the men. Don't be afraid, it's possible. And we also have very respectful men, especially nowadays. Therefore, to the women, do not be afraid. That's why I'm here.
Thank you. Kashna, why are you here?
This one is working.
Yeah, thanks, Ruth. Isn't that the question of the day? And let me say this, I actually am proud that I'm a minority here, a huge minority on this panel. This is my 6,850th day of my professional career. And from day one of this journey, technology for me has been a big enabler, dividing the gender bridge across. I feel that this sector, this space, digital health or technology, whatever we want to refer it to, has more potential to equalize the space for everyone. There is a team member in my team, and I would absolutely want to give kudos to her and share a short story, which is her journey. This girl started as an IT support specialist a few years back. And during her first few days in her job, the first job of her career, she was actually receiving glances from her colleagues. And she was an IT support specialist, so she was supporting IT equipment and the entire paraphernalia. And the question which everyone had, how come a girl handled computers? Is this even possible? And so proudly, she proved everyone wrong. She overcome all those voices in the room. And today, a few years down the line, she's a part of my software engineering team, and she's actually designing and developing software solutions for enabling healthcare access in the rural parts of Kenya, Uganda, and Burkina. This is one of the most inspiring stories I have ever come across in these 6,800 odd days in my career. I have been always of the belief that everyone is equal in this space. It's about merit, it's about learning, and my role is to enable the bottlenecks to be removed. So very proud to be here, and in minority, Ruth. I hope I have earned my place on your panel.
I hope the next time that we meet should be in the stage, not you. So let me bring on board Ezna. If you can hear us, I know you are joining us
Yes, I can hear.
from very far.
Yes, I can hear.
Why is this important to you?
It's important to me because, we talk about digital solutions and how we can bridge the digital divide and make everybody equal, and we have equal access to the services. But in the real sense, it also has a tendency to also widen the gap, which is a possibility that could happen. So me being here is lending the voice to this conversation to make sure that the opposite doesn't happen. That it does actually bridge the divide rather than widen the gap. So it's just lending the voice to that conversation to make sure that women are involved in the decision from the beginning of the design process and down to this implementation, so that we don't get locked out of the final fruits of the benefit of the digital solution. So that's why I'm here. It's very close to my heart. These are two things that I talk about all the time: digital innovations in health and gender equity. So it's a win-win for me all the way.
Thank you, Dr. Ezna. Now I want to go to Rita. Why is this important to you?
Thank you. So this is important to me because I recognize that I am, one of the women who has worked in digitizing ecosystems, not necessarily just health, but from my background in Safaricom, digitizing just end-to-end public sector ecosystems. So I'm here to encourage women who find themselves in sometimes this very bewildering IT digitization space, that it can be done. And that we're actually very good at it as women. So that's the first reason I'm here. The second reason I'm here is health is a matter that's very close to my heart. And as we digitize health, I want to be sure that we're digitizing health in an inclusive manner. I think it's fantastic to have initiatives in urban areas like Kisumu and Nairobi, but really the individuals who benefit most from digitization of health are those who sit in the far-flung areas of, for instance, Northeastern, and usually actually do not have access to electricity and to internet. So my question is, how do we push the envelope so that we're actually digitizing in the areas where we'll see the most transformation and not just shift the needle a little bit? So those are the two reasons why I'm here. Thank you.
Thank you. Dr. Margaret, you are the CEO of PS Kenya. How is PS Kenya leveraging digital health solutions to address aspects of gender that are specifically challenging to the Kenyan context?
Thanks, Ruth. So PS Kenya, in full Population Services Kenya, is a health non-governmental organization, and we are a local NGO with over 3 decades of experience working in this country. And you may know us because of the products that we have in the market, like Trust Condoms, WaterGuard, FemiPlan, and a number of many programs that we run in this country. So how are we ensuring that issues of gender are really integrated and included within PS Kenya? So this year we launched our strategic plan, a plan for the next 5 years, and we are looking at behavior change communication, social behavior change. We realize that women and girls have unique challenges, unique matters that affect them, including issues of teenage pregnancy, gender-based violence, and healthy timing and spacing of pregnancies. So at PS Kenya, we amplify the voices of communities so that these voices can be heard. When we are talking of gender-based violence, at the moment the national rate is about 13%, according to the last Kenya Demographic and Health Survey. And we are saying these voices of the people, because these are just statistics, but we need the voices of the people to be heard. And we utilize digital platforms to amplify these voices, including social media channels like TikTok, Facebook, and Twitter, or X formerly Twitter, various platforms where we get the voices of the people, of the community members to be heard. And we realize there's a unique cohort, this being the adolescents and young girls who are at a young age of shaping their lives and seeing, how do I plan for my life? So we collaborate with various stakeholders like the government of Kenya. That's a key player that we collaborate with counties, with development partners who support PS Kenya in doing the work that we do, including the US government, Denmark Embassy in Nairobi, the UK government, and foundations like Children Investments Fund Foundation. So those are some of the key players that we work with, and we have major campaigns that are out there. You may know us for Wacha Mpango wa Kando, that was there many years ago, but that was targeting the older generation. So if you're in this room and you know Wacha Mpango wa Kando, chances are you don't know about Chukua Selfie campaign, which is targeting a younger cohort. So we utilize these digital platforms to educate the people and to tell people about the voices or the discussions we are really having in these rooms. We also work in the private sector because we realize 50% of Kenyans access healthcare services from the private sector. And under the private sector, we support in increasing access to quality and affordable healthcare services. We also have a platform known as SaraMed that is utilized in select private sector health facilities as a resource management system where facilities are able to see the entire channel of the resources, the money that is coming in, the services that you're offering, and really having this business mindset. So those are just some of the examples on what PS Kenya is doing. Thank you. Thank you,
Dr. Margaret. Listening to you, you've been targeting individuals and more so the young people. I want to ask KK, now that you're working with community health promoters that are at the household level, where we have the young people, we have the old generation, how are you leveraging the digital tools?
A great question, Ruth. And let me take a step back on this. I think for us as an organization, this is not only about digital. I think this is a fabric in which Living Goods as an organization has been embedded in. And I want to share a few numbers with everyone here to respond while responding to your question. Our board comprises of almost 60% female representatives. Our executive team is also 60% of the female representatives. I lead the digital health team, which is about a 60-odd member team across 3 countries. And 40% of the leadership of my team is also represented by the female leaders. The point I'm trying to make is that as an organization, we realize how critical it is to the cause of improving healthcare access, the role of women at the last mile. And it's not only at the last mile, it starts from the leadership. Kenya happens to be still in a phase where the basic health outcome indicators are pretty low. They're not in a good shape. And community health workforce cadre is a very important one in medium to long term, to improve these health indicators and outcomes. What we do as an organization and to enable digital tools or the digital enablement of these workers in the field, and we have been at this for the last 10 years. It's also great to see how government has picked up the momentum, and now the electronic community health information system is across the country working. But what we have been able to do is to take inspiration from Kenya as a country, looking at how Kenya has been able to win the maximum medals in the marathon in the Olympics. And Kenya happens to be amongst the top 2 countries in terms of medal winners. And just like a marathon winner or a marathon runner, it is not only about who can run. It is not only about good nutrition. It is not only about stamina. It is not only about mental health. It is a combination of all these factors. So when we look at digital enablement of the community health workforce, for us as an organization, it's not only about building a workflow or an application. We bring in the programmatic perspective to see what the health needs are. We bring in the user-centric perspective. For us, it's very important when we talk of digital interventions, is the work which we are doing, is it user-centric? For us, the core principle is build with the workers and not with engineers. So we actually work in the field to take that feedback, to help look at the design, to develop tools which act as a job aid and not as a job add. Because we are talking of a cadre which is at a very different stage of digital literacy compared to some of the smartest people sitting in this room. Second aspect is around their capacity building. How do we help do that? And we are not merely talking about training. It's about essentially, the way we look at it is life skill, imparting a new life skill to someone in the field. A majority of these community health workers have never used a smartphone before. And this is the first time they are possibly even holding a smartphone in their hands. So it's not easy to make that transition for these workers. So how do we do that? How do we identify and distinguish slow learners and fast-paced learners? How do we bring them together and have a curricula which helps them understand that this new intervention is actually supporting them, is easing their workload, is helping them to do more at a more efficient pace. It's also about looking at the long-term roadmap, how the technology is going to work. At the end of the day, technology has to do its job. So how that technology is going to work. It's a solution for 2 years down the line. It's not only a solution for today. We have a very strong field tech support team which works in the field, and these are the local guardians for these community health workers, which work on a day-to-day basis, hand-holding these workers as part of their training, as part of their onboarding, and also being available to resolve technical issues in the field. They sort of become their counterparts from a digital standpoint while the workers are doing the work in the field. This layer also plays a very important part to capture the feedback from the workers. What's working, what's not working, how the design has to be improved. The second last element which we focus is, and I'm not even touching the programmatic elements, I'm still sticking to the digital side, is the use of the metadata analysis. What is that metadata, the system data, which is, what is it telling us? There are cohorts where we find, due to this work, that the adoption of the system is high compared to another cohort and another region in another branch. So what is working in one region with the same system and what is not working? Why the adoption is low? What happens when the workers are syncing data or not syncing data? So if a worker crosses 7 days of inactivity or 30 days of inactivity, there is an intervention we have to do and we have to find out what that is. So there's a lot of metadata analysis which we do internally and then follow it up with an action in the field. And I think the last point I want to make is that this is a marathon we are actually running. We have always looked at it as a marathon, not a sprint, 100 meters. And no marathon in this space can be run without government ownership and partnership. For us, the work which we do with our focus on enabling the government systems to work with governments and take their lead to actually do the work is very, very essential. I have to really applaud the work which is happening in the Lake region. This has been an exemplar for so many other regions to follow, not only in Kenya, but in so many other countries in Africa. The ownership and the drive which the government here has shown is really exemplary. It's not easy to see, and that has really helped us to move and enable digitally the workers in the field.
Thank you, thank you. Just hold it there. I want to bring on board Dr. Ezina. You've heard what KK has said about the digital solutions not just being solutions. There are the issues of usability, user-centric, making sure that we are giving people life skills. They have to be dynamic and adaptable, government leadership, and so forth. So KK, Ezina, you all are digital health strategists. You've worked in this space. From your perspective, what are the most promising digital health threats in addressing healthcare needs in Africa?
That's great. So he said really amazing things. And before I really go into that, I just want to add a few things to what he said around the challenges. Because before we talk about solutions and trends that are really popping up now or have been there for a while, there are challenges that these trends address, such as we have acute healthcare workers shortage in Africa. We have just 3% of the global workforce, and we have 24% of the world disease burden. And the high disease burden of communicable diseases, NCDs are on the rise. And then maternal child mortality we have the highest indexes on the globe. And of course, poor health infrastructures as well. So talking about the trends, digital health trends that are promising and addressing some of these issues. The first is telemedicine and remote care, and that's popular because I think what one of the panelists said earlier around making sure that digital health solutions are not just for the urban areas, but as well as the rural areas. We see that's why telemedicine during the COVID areas, yes, it came out of a necessity to be able to reach everyone because we're all locked down. But then we've seen the need for that beyond just that, we're moving into areas where there are fewer health services or not enough health professionals. So that helps address the challenge of shortage of healthcare workers. We've seen that we roll out big time in Rwanda, in Babio, Rwanda, where they have mobile phone consultations with doctors. Poor health infrastructure is also addressed by telemedicine because you have those locations that people don't have to go to the health services service centers anymore. And high maternal and child mortality is also addressed by telemedicine and remote monitoring because you have some apps and some platforms like there is one called Safe Delivery app that has instructor videos and guidance for pregnant women to go through for their antenatal. And then secondly is the big word, the AI tools. Definitely, we can't talk about digital tools without talking about what the advances we've had in AI across the continent and across the globe. So we have them as clinical decision support tools for diagnostic support and also for X-ray and medical imaging. So these help a lot to diagnose disease, and also for TB. This is helping a lot in South Africa for TB, for the X-ray diagnosis and addressing those high burden diseases that I talked about earlier. And health services, mobile health services are another one that really, it's on the rise and it's very promising. So we use it for training healthcare workers with apps, for instructional videos, for guidelines, for all sorts of things. We use mobile platforms for that, and also for SMS-based. So that's also another low-hanging fruit. So one was also mentioned earlier about places where you don't have internet. So you can, because we have high mobile penetration but low internet penetration, you can use SMS-based platforms as mobile platforms to reach people who don't have internet services. So for the financial, the fintech processes to get into the health tech space with mHealth. And wearables, we have Fitbits, we have all these diagnostic tools that for diabetes, for heart rate, for the different chronic illnesses that can be connected to monitor healthcare outside of the healthcare space, especially where you don't have enough doctors. And I'll just mention the electronic health records. It's one that has come up, it's promising these days. In as much as we have issues of interoperability, but it's something that we can also leverage on because we have, if we can get our systems to speak to each other, records across systems, then I am not stuck to going to one health facility because I know that my records are across other facilities, and it reduces the burden on the facilities in one area when I know that I can go to another facility in a different area and also get my health records there. So these are some of the promising digital health trends that I've noticed, and as well as blockchain for supply chain management. We also use that for counterfeit drugs. I know for example, Nigeria that was widely used for malaria tracking. So that's something else that has come up. So holistically, looking at capacity building, e-learning platforms that have come up for people to build capacity for healthcare workers, which is one of our biggest challenges. It's a trend has coming up as well that it's promising. All these training capacity platforms, mobile health, all the trends I've mentioned, all of them are great. And then finally, before I just wrap up, looking at one of these platforms like the DHIS2, which is a holistic tool that combines everything, points for a lot of health, a lot of governments to have that data-driven decision making from everything put together in one tool, like your LMS, your surveillance, your pharmacy tracking, your supply chain, all of that in one tool. We can have that together, then we can make decisions that are data-driven. So these things I've mentioned can address the challenges that I've mentioned, and you can see things going hand in hand and not just working in vacuum, but doing that your solutions are addressing specific challenges. Thank you very much.
Thank you very much. I want to go to Rita. You've heard what Ezina has said, and I like that she brought about the contextual solutions, issues of interoperability, sharing of data, decision making, and so forth. You've worked with Safaricom, digitizing public services, and you've listened to the rest of the team talk about what they think good solutions should look like. What's your take? Key learnings, digitizing public facilities or public sector?
So maybe I'll share 3 learnings that may not necessarily, I think it relates to health and to everything else. So first of all, we shouldn't fall into the temptation of digitizing a flawed process. So if a process is already inefficient, moving it off paper onto a computer doesn't really help. You still run inefficiencies and additional costs because you're still going to run the sort of semi-automated environment, which is a lose-lose for everybody. So that's the first thing. The second thing is you cannot digitize in a vacuum because technology changes really rapidly. And if we're doing any large-scale digitizations right now, we have to be AI ready and future fit, because when AI comes in, a lot of the things that we are doing now that seem very novel will actually be something that a machine can do in 2 seconds. And some of our business models will actually be wiped off the table. I mean, if you doubt me, speak to Kodak. I don't know if you guys remember Kodak and the pictures we used to take, they've been wiped out. I think third and most important is technology to be efficient in the public sector must be at scale. And it's great to have different initiatives, and I'm in no way downplaying what we are doing, but I think at some point we need to aggregate what we are doing. If we look even, say, for example, maternal and child health, we all have very many different programs that are running, but the thing about technology is it's supposed to drive efficiency, it's supposed to bridge distance, and drive consistency. So, you know, the reason why M-Pesa works, for instance, is because you know exactly what to expect. You know how the app will look, what you'll see when you get there. It's consistent regardless of where you are. Until we drive that consistency in experience, then it's very difficult to see the benefits of digitization. And I think it's time we thought about, you know, which donor agencies, which technology companies are good at what, and how do we plug into, the digital health exchange that's being built at a government level? Because what you don't want to have is to have a shift process, then our own processes for the same services. That doesn't shift the needle. So I think those are the 3 or 4 things, but we have to make sure that we optimize the process before we digitize it. So if the process is not optimized, just digitizing it doesn't mean that you decongest your level 1 and 2s and only have, your level 5 and 6s and only have referrals going there. If you don't have the doctors, you don't have the entire ecosystem, it's actually not helpful. So it's an ecosystem approach, and you have to digitize and optimize process, simply because digitization is really expensive and it takes a lot of time to do. So you have to already be building a solution that's 2 or 3 years out. Otherwise, within a year or 6 months of use, the technology is redundant and somebody comes in with something better. So those, I would say, are my learnings in the digitization space.
Well, still having the mic, maybe you can just speak to how KRP model is helping to make healthcare more accessible and affordable in our context in the East Africa region.
So I think there are a couple of things that we do at CarePay, and we do it also in conjunction with our partners. We work very much with partners because we are really a tech platform. One of the bundles that we have is what we call the Mom Care and Mama Toto bundle, and really speaks to the nexus of innovative care models coupled with good technology. Now, what Mom Care does is that it allows mothers to pick a hospital of their choice and work with a mobile-first approach. I've had that a lot today about, how do we put the mobile phone at the center. And through this process, the mother follows a prenatal and antenatal journey that she goes through with a specific clinic. Now, it's not just about, the patient. It's also about how do you incentivize the providers. Providers are a very important cog in the wheel when we talk about healthcare. And what we're able to do working with partners like Farm Access is to make sure that the safe care model creates a standard to which these providers have to live by and give a very good experience to our customers. It then allows also a bit more flexibility in terms of innovation in funding models because you're not necessarily just looking at an own funding. This is an area where you can get donor funding because it's very specific. You know exactly where the funds are going, what they're going to do, and you can also track the journey of the mother end to end in totality, diagnosis, pharmaceuticals, and so on and so forth. The other thing that I would also like to say is that as we think about digitizing healthcare, we have to move a little bit from our traditional health models, which was donor-driven. And this is no offense to the donors, but traditionally donors would fund TB, malaria. We had different pockets of funding. And sometimes you find that it's the same patient who goes across these verticals. And when we digitize, we need to follow the patient and not necessarily the ailment. And I think it's really important that as we think about digitization, we are mapping a patient end to end and not an interaction at the point of seeing a doctor for a certain ailment. So those would just be my thoughts around that. Thank you.
Thank you. You've brought us to the aspect of holistic approach when you're coming up with digital solutions. Keke, 1 minute. I know you articulate the qualities of a good solution, digital solution. Can you speak to one that you've seen work? Just 1 minute.
Yeah, this is, I think, the most difficult question because I have to pick one now. Look, I think it's for us as an organization, the focus is around performance management. We are not doing digitization to distribute mobile phones. We are not doing digitization for the sake of doing digitization. I think it is about, for us, it is about problem solving in the field. What is going to enhance the ability of the worker in the field to do the same job in a more effective way, in a more impactful way, and which is what our focus has been on performance management. How do we use these digital tools to enhance the performance management in the field, which then triggers off better supervision and mentorship of these workers. So I think if I have to pick one, it's the data use. And I spoke about one bit of metadata analysis of how we use data internally. to enhance the digital solutions itself. But even on the programmatic side, we do not look at dashboards as mere compilation of numbers. We do not look at dashboards in the form of data mining or MIS. For us, dashboards are systems which should tell the end user of what should be the priority today. What is it that you have to do in the next 2 days? What are the households you have to follow up? It's not about a compilation that there are, XYZ households in your region. It's about, out of those XYZ households, how many are the priority households? Who are the pregnant women? Who are the children who have missed vaccinations? So the focus has been to bring data use to a point where the system is enabling job aid of the worker and not just creating a view of data. So I think that is one thing which we have found very impactful, and that I'll say that is one of the most effective ways of making an impact.
If I heard you, you talked about automation versus performance management. Are we just automating processes, or are they helpful to the people who are using them? Performance management. That's so?
So I think Rita also spoke about that. If you have underlying inefficient processes, then digitization can only go as much. So I think we also, and again, I think this brings me to the point of innovation. As a technologist, I can obviously go gaga about all the technology trends which are happening all over the world. But what is the problem we are trying to solve? And if the core underlying problem is not getting solved, then I might do AI of all the world. But it will not work if there is no internet. It will not work if the requisite infrastructure is not there. So I think that's where we start, and then we look at how do we enhance that.
Thank you very much. Dr. Margaret, entrepreneurship, getting to the last mile. How is PSK using innovations to make sure that we are improving service delivery in the last mile, and especially women in underserved communities? 1 minute.
Great, thank you, Ruth. So when you're dealing with people and trying to reach the hardest to reach, the easiest way of reaching them is using what is already working, as opposed to creating another channel and trying to make it work. So number one, using whichever channels are working, what we are doing is really targeting these communities, and not just PS Kenya, also many other players. For example, using radio, because many people are really listen to radio. There's TV, there are digital channels. Therefore, when working towards influencing, and especially gender-specific illnesses, these are very key channels to utilize to get to the underserved or the hardest to reach communities. And while utilizing these channels, another critical thing is who is giving this message. Because you need a trusted voice in that community to give that message. Not necessarily the expert. That may not be the trusted voice. Margaret may go and speak there, but I may not be the best person. But there's a religious leader in that community who's really trusted. That is the right person to speak to the community about that message. So what we do is equip the influencers with the skills, and influencers may be different people, religious leaders. There are also social media influencers who are reaching key populations, especially the younger populations. If it's the older generation, working with politicians, musicians, including Samido, those are key players who cannot be ignored as we are trying to change and to improve the behavior of people while in communities. Also, another strategy of getting to communities is listening to them. And that has already been alluded to earlier in this panel about co-designing, co-creating, utilizing human-centered design, and using experts like Buni Banda, who are experts in human-centered design and research work, and really sitting with the people to understand what is it that they want. How can I get to you? What are the barriers that are preventing you from taking up a certain behavior or channel? And what are the facilitators? How can I get better to you? Also, for example, when we talk to the younger people, some of the things they talk about is confidentiality and privacy, especially matters to do with healthy timing and spacing of pregnancy, family planning. That's a very key channel. That's a very key issue about privacy and confidentiality. Therefore, when designing tools or systems or digital platforms to get to these people, privacy and confidentiality must be assured so that the people who are being targeted can pick up the interventions that are desired. So those are just some of the examples, and there's so much more that we could talk about. Thank you.
Thank you, Margaret. You introduced something else, that it's not just about digital tools. There are already existing channels that we can leverage together with the digital tools to ensure that we are reaching the last mile, our women and underserved communities. You brought about the aspect of privacy, confidentiality, and I want to maybe bring now Esna on privacy, confidentiality, and how do we make sure that we are considering that as we come up with digital health strategies that are gender responsive and inclusive, but also taking cognizance of those needs of people who require privacy and confidentiality. Over to you, Zina.
Thank you very much. So this is a two-pronged question. So first of all, addressing confidentiality and privacy in having the strategies that have to do with gender sensitive and gender responsive. For me, you have to start from the very beginning, because we live in a digital world that is gender biased as it is. So if you're going to start, before you even start the design process, you have to conduct a gender sensitive needs assessment. Or even if it's not gender sensitive, you need to do a needs assessment to let people understand why there's a need to collect that information or do sensitive information from them. So if they have that understanding of the why do you have to get this sensitive data from me, then they will have a better appreciation of why they have to give it. And then that's the first step, having that assessment prior to you even going into the design phase. And that's something in the gender space that Tanzania has done very well. Sorry, I keep giving examples because I've worked really with a lot of countries. Tanzania has done very well with their gender digital health initiative. And before you go into any mHealth application or whatever you're doing with that space of telemedicine, you have to make sure that you do this assessment first that are in that gender sensitive, to make sure that these needs of the women, the gender-based needs are addressed. And of course, the aspect of also the data sensitivity and the privacy and confidentiality. And then when you move to the second part of the design process, co-design with people. It's been mentioned a lot today of co-designing with people, because that gives them transparency of, okay, this is how this process is being done. They're not just playing around with my information, but a better understanding of this is how our data is being used, this is how the system is being designed, and this is why they needed our information or why they need our data to be able to produce outputs that will yield results for us, for our betterment. So you co-design. And in the gender space, working with people, for example, in the maternal and reproductive sector, having women co-designing with rural women, like Mom's Initiative in Nigeria, is something that is very applaudable. Like it's very amazing, because these women understand why, because that's a sensitive issue. It's a very sensitive issue. It touches issues of data privacy, it touches issues of gender, when you talk about reproductive maternal issues, health issues. So that's a very good way to go about it. Doing co-design with the people who are marginalized. They are marginalized, they are women, there has to be data privacy. So that's a very great approach to go with that. And then finally, at the post-design implementation phase, make sure that there are policies that encourage that what you said you're going to do is actually what you do. So it's not that you tell us you're going to start with this, or we're going to do with our data. This is all the things you're going to do with the information. You're going to make sure this is gender, there's equity, and it's relevant to the women. The women have access to it, and at the end of the day, they don't have access to it. So are there other programs that go hand in hand with what you're developing to make sure that these women even have access to programs that you have developed for them? So that's very important. Our policies and strategies go hand in hand to ensure that this, the promises that are made at the beginning are actually implemented. And then finally, generally with the government, they have to promote these digital health strategies and initiatives for countries that protect people and that protects data and implement these strategies as well, not just developing. I know we developed a lot of things during the COVID years, but many of them were not implemented. Some have expired. So it's necessary that those, and that's how you can actually, within the law, protect the rights of people, the data of people. And also that also happens also when you bring it into the gender parity aspect, having that gender parity in digital health leadership. That there is that when you're bringing in those laws, people who are making those in those leadership positions are also women, so that they can tell you how they want to be treated and what applies to them. So, and just to wrap it up, the digital health, I think the African Union Digital Health Transformation Strategy really went a long way to, it had a lot of stakeholders contributing and put in all these different aspects, and it's a very beautiful document to look at. I'm sure a lot of us here know about it, and that has led to the development of a lot of initiatives around women in digital health and initiatives that are helping to consolidate some of this. Someone also mentioned earlier, we are all over the place somehow with pilots, we are not scaling up. So having that conversation of everybody come to the table, not just focusing on donors, but having a PPP, public-private partnerships as well, so that we don't have data flying around everywhere and disparate sources and different health systems having everybody's data, but everything coming on into the same pool, and people seeing the effect that they have given you their information, and this is the effect that is yielding. They're having the benefits of the information they have, the data they have given you is yielding information that is beneficial to them. Thank you.
Thank you very much. We are coming to a close, and you've brought up very key takeaways as a way forward, making sure that we are co-designing after doing an assessment, being respectful of the rights of the people that we are supporting these solutions and making sure that our solutions can scale. For my panelists who are here, just less than 30 seconds. So what? Starting from here.
So what? Investment in digital health is costly, but it's a cost that needs to be done. And even as we invest, we need to remember the women, because of the unique challenges affecting the women, especially issues to do with gender-based violence, teenage pregnancies, and it takes a higher investment to reach the hardest to reach. Therefore, as we're investing in digital health, it is going to cost more to reach the underserved, and we need to remember we should leave no one behind. Engage with us further on our social media pages, on PS Kenya, across all the different platforms. Thank you.
So what? So I'll come back to the story where I started. You know, my team member who started her journey, and she had to answer to those glances, can a girl handle computers? I think we are at a stage as part of this broader journey where when a girl today joins the digital space or a technology space, those glances are not there. And that's a big movement forward in the last decade, 2 decades, 3 decades. I think for all of us, it's very important that how do we enable this girl to move to a leadership cadence? You know, how can she start leading the work which is happening, the transformation which is happening? And I think for that, it has to be done by design. It has to be done more deliberately. And people like me, the odd man out on this panel, has to continue to do the nudges as part of the system.
Thank you, Keke.
So what? I think the first thing is scale. We need to have a digital health proposition at scale to really enjoy the benefits. That would be the first thing. The second thing is how do we get many more women into the pipeline? So other than just providing solutions for digital health issues for women, how do we get more women into the digital health space in places of position, in places of decision-making and power? And I'm thinking of the pipeline right from school, where we encourage women to take STEM. Because if you don't have women who are in that space, then the pipeline is very narrow to pick from. And obviously women will be able to better articulate and better design intuitively for female health issues. So it's a dichotomy for me. Thank you.
Thank you very much. We are coming to the close. Sorry, we may not be able to take questions, but the panelists will be available to answer to any questions that you may have. And I want to close by recognizing the support of PS Kenya. It is courtesy of them that this has been made possible. Thank you very much. Talk soon.
Thank you very much. What a panel. And thank you, sir, for representing us very well. If you meet that gentleman, just greet him, tell him, thank you very much. You really did represent the men in that panel very well, discussing this issue of women and digital health. Now, ladies and gentlemen, I'd like us to move to the next panel. And this one touches on digitizing community health systems for better health outcomes. And for this discussion, we raise a very important question. How do we strengthen community health programs? If you're here during the fireside chat, there are some very pertinent points that were raised earlier on in regards to these issues, and we want to dig deeper into that. But before we do that, I'd like to recognize these wonderful people. When you look at our logo, you can see down there, yeah? We have quite a number of people. You can also see there, these are organizations that have made this conference a success. And we want to thank Farm Access, LREB, PS Kenya, Living Goods, Pathfinder, Kenya Health Informatics Association, the Government of Netherlands. We also have the hosting county, Kisumu County, and the co-hosting county, that is Homa Bay County. Later on, I'll also be mentioning some of our sponsors and our partners as we proceed. But at this particular moment, I'd like to invite the moderator of our second panel this afternoon, and to take us through digitizing community health systems for better health care outcomes. I'd like to welcome the Global Digital Health and Government Partnership at Living Goods, Hilda Ngondoki. Ako wapi Hilda? Mpigeni makofi tafadhali. Come on, appreciate her. There we have Hilda. Those stairs, they can do you wonders. Okay? There you go. So the floor is yours. As I've always said, this is your home. Feel presidential. Your top is even matching the floor. It means you're destined to be here. Enjoy.
Thank you so much. I'm seeing I have 5 panelists. Is it possible to have an extra chair? I don't want to create a teacher-teacher situation by standing and having the panelists seated. So thank you all for joining this afternoon session. It's raining outside, so I'm kind of happy about it because I'm going to keep you in this room. Our panelists are very interesting, and before I introduce them, I'd like to introduce the session itself. So we'll be discussing digitizing community health systems for better health outcomes. And we've had a lot of digital health talk throughout the day. And 1 year next week, it will be when the president launched UHC, Universal Healthcare, part of which includes professionalization of community health workers. And professionalization includes equipping. And part of equipping is tooling using digital tools. So our session today will focus on strengthening the digital health systems by looking at sustainability at scale. So allow me to introduce my panelists. Sorry for that. So joining me, we have Gabriel Masinde, Community Health Focal Person from Vihiga County. Please join me on stage. We can clap. We have some energy to clap, right? Thank you. And then we have Dr. Maureen Kimani from Division of Community Health at the Ministry of Health. We also have Eugene Mushai, Community Health Manager at Amref Health Innovations. And then Gitai Nganga, Director Software Engineering at Living Goods. And Roy Bore, CEO HealthX. Are we all here? I seem to be missing Eugene. Okay, there we go. So, as they make their seats warm, we expect you to pick out the key strategies and mechanisms for addressing emerging Lake Region digital health solutions, priority areas that need strengthening, and approaches to integrate innovative digital health solutions in the region. So, one last welcome round to the panelists. Okay, so we'll start with Dr. Maureen. So, please expound on the critical policies and regulations that the ministry has put in place to ensure that we foster a sustainable community digital health ecosystem.
Good afternoon, everyone. So I'll be very brief because the community health story is very long. We can talk about it for a very long time. But just to go back a bit and say why we are very particular, and this is not just a Kenyan agenda, this is a global agenda, that health really starts in people's homes. And therefore, if we can get people who are trusted in the communities, especially in the rural, underserved communities, who can keep on reminding community members about health-seeking behaviors, about eating healthy, about water and sanitation interventions at the home level, then we're going to have a very, a much healthier community, and also deal with all the other issues around the health indicators around under 5 mortalities, infant mortalities, maternal mortalities, as well as just a healthy population is a more productive population. Therefore, people are able to work and not be time. If you look at the top 10 health conditions in the country, most of them are preventable illnesses. A child under 5 in this country will die of diarrhea. Diarrhea disease because of maybe hygiene issues at home, maybe because the mother could not access simple zinc and ORS, simple interventions that can be given at home for children. And therefore, from 2006, the Ministry of Health has been implementing the community health strategy, which has evolved over time up to what we are having currently as a big at-scale program, which is being implemented across all the 47 counties by over 100,000 community health promoters who are members of communities who are trusted. And most of these people are in underserved, informal settlements in the rural areas and in the areas where these services are really needed. And therefore, what we did before is that for the services that they provide, we need data. We need to know what are they doing in the communities. And we had almost 8 registers, 8 different registers. There were actually A3 booklets because every single technical unit in the ministry wants to add an indicator. So the maternal health, they want like 5 indicators. Child health, they want 6 indicators at the community level. NCD want indicators. And therefore, the tools became bigger and bigger and bigger. And therefore, a lot of partners, right from 2013, had already begun implementing vertical standalone digital solutions. And by the time we were coming to the rollout of UHC in the country around 2018, 2019, we decided let's just scope around and see what's happening in the area of digital tools in the community space. So we did a landscape assessment in 2019, 2020, and what we discovered was there were more than 28 digital solutions that were being used at the community level. And in some instances, we had community health promoters. When we went around the counties, we had community health volunteers then who had even 6 phones. So they'd have a digital solution on malaria on one phone, a nutrition solution on another phone, and they have a child health solution, and the partner wants their indicator, so they have given them a phone. And so when they go to a household, if they are taking care of malaria, they pick the malaria phone, enter the data, then they say, oh, there's a pregnant woman here. Pick the other maternal health and pick the data. And the CHPs, when we talked to them, they were really upset. But they said, since I'm getting an incentive for each of these programs, then I need to feel for each. And so the landscape assessment really was the basis for us to actually start this big digitization agenda in the community health space that we have been running since 2020 when we developed the community health policy. And within the policy, in one of the policy directions, we actually talked about digitizing community health systems. And after that, we developed, together with all these different partners, the 28 different partners who had individual solutions, we brought them to the table and we told them this cannot continue. And so developed the digitization strategy. And from there, we looked for a strategy, a solution that was very much integrated, had all the areas that the community health promoters were already doing based on the paper-based tools. And that is what we have been building until last year, where we now rolled out the electronic community health information system. And we are very happy that by June, the scale-up has happened very rapidly, and now we are thinking of other things. So initially we had no scale-up, no digital systems. Now we have scaled up. Now we are thinking, how do we maintain that system? Thank you.
Thank you so much for that, Dr. Marine. And you've spoken about centralizing and standardizing the digital health systems. Let's hear from Vihiga County. What lessons can other counties learn in your experience in leveraging technology to improve your community health systems?
Okay, good afternoon, ladies and gentlemen. My name is Gabriel Masinde. I coordinate community health services And I also want to recognize my colleagues from Vihiga County who are here. I have Director Public Health and also the head of digital health, in charge of digital health from Vihiga. Colleagues, you can just raise your hands. Thank you so much. So Vihiga, I can start explaining digitization way back before the year 2022, when our governor thought about digitizing community health in his manifesto because of the high cost of registers, the manual registers for community health, that even made some development partners to shy away from procuring registers, and it became also very expensive to the county government. And then now he said that since we now have a stable stipend payment program where our CHPs were receiving stipend consistently, and also Vihiga was 100% community health services covered. We had CUs in all our sub-locations in Vihiga. He now thought of digitizing community health. And then, so it was in his manifesto, but then we couldn't actually know exactly what we could do to digitize community health services. But lucky enough, we developed a collaboration with the Living Goods, which came in at that particular time. And then they collaborated with the county government of Vihiga and came up with a co-financing plan where it spelled out the roles of each partner, the Living Goods, and then the county government of Vihiga. So that conversation went on, and as we were thinking of how to procure the devices for the community health promoters, because Vihiga has a total of 1447 community health promoters, the national government came in and procured devices for community health promoters, and then now Living Goods procured devices for the community health assistants. And then now we began the journey of digitizing community health services by training all our community health assistants and all our community health promoters. So after that training, we went straight away to start registering households into the national program, the national platform that is Afya Nyumbani. And this is something that we did quite very fast because digitization made everything easier. Remember, we used to do the manual way where we could, CHPs could move to the households with those big registers that sometimes could scare even household members. But now with the digitization, things were done very fast, and we were able to register a total of 146,000 households within a very short time. 146,000 households within a very short time. And we continued with the assessment of household members, and the work became very easy. So what I can say is that digitization has worked so well for Vihiga County with the support from partners, and more so Living Goods, which is supporting us, especially in technical expertise from their staff. So it has enabled us, number one, to reduce the cost on paperwork. Somebody said that counties are not showing the case on how digitization has helped them reduce their budget. But when you come to Vihiga, we can demonstrate clearly how the county government has reduced its budget on paperwork, especially in the community health space, where now we are no longer procuring all those big registers. Remember, CHP alone had 2 big volume registers, that is MOH 513 and MOH 514, which were big volume registers. But right now, that budget has been cut off, and so we are doing very well. The other thing is that we are collecting accurate data, because when CHPs go to the households with their devices, they get information in a very easier way, and that information is easily transmitted to the system, and the data that is collected is very accurate. Before that, the data was very, very inaccurate, because sometimes we reached a place where we could not procure those registers, and then now the CHPs could go to the households using their notebooks. And when they use their notebooks, they don't collect all the information that is required. Sometimes they just pick on a few indicators, and now they collect very scanty information that could not make any sense. But right now, with the digital system, they collect accurate data with all the information that is required, and therefore it can make sense out of it, and it's reliable data that even other programs are leveraging on that data that we collect from the households. The other thing is that the data is real time. Take, for example, when a CHP is doing an assessment, they are able to identify cases very early enough, and that is the essence of primary health care, that we reach to the household members and be able to identify cases such as non-communicable diseases. Communicable diseases can be identified very fast and also referred to the health facilities. So we have a lot of referrals right now done to the health facilities just because of the digitization. Again, it has also improved maternal health, because as they go and make assessment to the pregnant women and also newborns, they can easily identify some kind of ill health and then refer to the health facilities. And that has again increased the workload in the health facilities in Vihiga, whereby right now if you go to Vihiga, you'll find quite a number of clients at the health facility, and therefore it has also improved the health-seeking behavior of the community members of Vihiga just because of digitization. The other thing that I also want to say is that digitization itself has made it easier for the community health promoters to deliver health promotion messages, because the messages are standardized, and therefore they can deliver standard message across all the households. And those messages being standardized, now the community health promoters, they have confidence of delivering those messages. Before that, community health promoters used to shy away from visiting certain households because fear of being interrogated and even asked some questions that they could not answer, because they are not confident enough that the information they have is the accurate information. But right now, with the standardized messages from the digital devices, they make them bold enough, and they will confess to you that right now I'm able to visit all the households because the information that I'm delivering to that household is already in the system, and therefore I don't have question marks about the information I'm giving. Something that has really improved even the sanitation standards in the community, because we have in their workflows, we have messages on WASH, and we also have messages on non-communicable diseases and all cases that are found in the community. So for us in Vihiga, community health digitization is really working for us. The other thing is that we were thinking of how to come up with a performance-based compensation, but we could not exactly know exactly what to do so that we can pay our CHPs based on the performance. So we were just paying stipend wholesomely, but right now with the digital system, we are able to come up with the performance and compensate our CHPs based on the performance, because the system can easily calculate and give us the performance rate of each and every CHP, so that now we can compensate based on the performance. Thank you.
Wow, isn't it wonderful? Vihiga is experiencing the true benefits of digitization. And I can see Dr. Maureen is smiling because she has put a lot of effort. And just to echo what I've heard from the two groups, we have policies, we have standardization, we have partnerships and collaboration and capacity building. So for my next question, which goes to you, Jane, as we can obviously see from the two accounts, digital health tools really enhance the effectiveness of community health workers. How can counties maximize innovations in healthcare to improve service delivery?
All right, thank you so much, Hilda. And I think I've learned quite a lot from my predecessors in terms of what is happening at the county level and also at the national level. I want to start by talking about access to healthcare, because that becomes one of the most fundamental aspects of access to healthcare, becoming fundamental to how we save the situation in the country, and especially dealing with health from the community. So when you look at the way community health workers operate and the kind of support that they have received so far, we've heard about the digital tools that they have. They have mobile phones or tablets to do some form of data collection, form of reporting, and also have some lessons. So in addition to the endowment that has been done and the digital tools that they have received, especially the tablets and the mobile phones, the governments, both national and county, would be better off at least increasing the access to those devices across the county, so that now we have more community health workers being able to deliver healthcare at the community level, at an advanced level. So looking at the current work that has been done, but now we need to do a little bit more, because the numbers that we have seen in terms of the people who are given the mobile phones and tablets last year when we were launching the UHC on Mashujaa, and looking at the need that exists in the community, then we are still very far off getting to the target of solving the problem of access. Looking at, for example, what more can the digital devices that the community health workers have, and how can it help us to grow? So if we have more devices in the community and we are able to do more, then we can achieve more results. What more can we do? What more can we do with those devices? I'm looking at a place where we can enhance learning through the digital devices, refresh learning for community health workers so that they're able to do more and more work at every step. We have such a solution at AMREF called LEAP. It's a learning platform where community health workers are able to get learning on, for example, cancers, non-communicable diseases, and many other diseases. And so if that model could be replicated in the government's agenda to improve access and capacity of the community health workers, then that is a step in the right direction. Community health workers can also use, through the support of government and other stakeholders, can use digital devices and digital tools to help collect data and make it more real-time and more relevant to the community. You realize that currently the systems that we're using to collect data must be a little bit more organized. We have to plan for research, do mapping at certain stages. But how about if we can collect this information in real time so that we get real-time data, make decisions faster, and therefore we can improve the way we deliver healthcare in the community. I'm also looking at a point where that real-time collection of data through the mobile devices or digital tools can help us to utilize technologies such as AI and machine learning to be able to understand what patterns are happening in the community in real time, because the data is being collected, and so we can pick emergencies here and there, as well as being able to do disease surveillance in good time. What happened to us, and this is not just a Kenyan problem, it's a global problem, what happened during COVID-19 is that nobody was ready for such a pandemic. Not enough surveillance had been done, and part of it is because data was not being collected in real time. So the kind of approach that we use right now should be able to help us to predict some of the diseases and pandemics that might be in the offing in the future. I'm also looking at how community health workers can be supported through being able to utilize new technologies, emerging technologies. And so there's more to do with capacity of the community health promoters in terms of utilizing digital tools and being able to make decisions from the digital health tools that are being used. We might be asking ourselves, but how do we get to that vision? How do we really get more devices? How do we get more training? One is if we can support the health entrepreneurs that exist. We have one of them like HealthX. I know Roy will be talking more about HealthX. So such technologies that are happening amongst entrepreneurs, those are technologies that we can borrow and actually support. The other thing that I'm looking at is, for example, if we can do more public-private partnerships to ensure that we have enough funding for governments at both levels to access the devices and the technologies, then that will also help us in terms of ensuring that we can have the supplies and therefore do the rest of the part in terms of capacity building and so on and so forth. So those are just a few examples. And I'm looking at one of the projects that we have done at AMREF. We did a mapping for how we can empower more persons with disabilities to access digital health tools so that they can help us with screening in the community, as well as being able to report like any other differently abled or abled persons in the community. So looking at how we can enhance equity through digitization is also another agenda that counties can at least adopt. Out of that mapping that we did, we realized that persons with hearing impairment, persons with visual impairment can actually perform equally well as non-disabled persons by just being able to access digital platforms and digital tools to do screening and community health work. And that is something that we can work together to achieve. Thank you.
Fantastic. I like that now the community health workforce has the digital tools. We have the opportunity to introduce innovations that also address the vulnerable within our society. But as we talk about systems and running systems at scale, for you, Gitahi, what challenges are anticipated and how can they be addressed?
Yeah, thank you, and good afternoon, ladies and gentlemen. Yeah, I think the first one is right there in that word, scalability, right? And often we have good intentions, and so we start to develop these digital health interventions, and we pilot them at a small scale, and they show some degree of success and promise. And the temptation typically is to say, okay, this works in Kisumu, in 2 sub-counties, what do? We take it to the rest of the county. Okay, it works for the county, what do? We take it to the rest of the country. And the challenge with that is, for all our good intentions, the sort of technology and infrastructure you need to serve 100 users, 1,000 users, maybe even 5,000 users, tends to be vastly different from what you need to serve 100,000 or 1 million, or even in the case of ECHIS now, 100,000 CHPs, 100,000 odd CHPs across the country. And so I think thinking about readiness for scale, designing for scale, either you do that from the beginning or you at least acknowledge that what you're doing is you're running a pilot program, and you want to prove that the concept works. But you have to understand that when it comes time to scale, it becomes a completely different ballgame. And often you have to take a step back and think about, okay, this works at this scale, but if you're going to take it to millions of users, then there may be a couple of things that you have to change fundamentally, sometimes including re-engineering the entire solution. Many of us know about DHIS2, for example, but have you asked yourself why it's called DHIS2 and not DHIS1? Old-timers like Momo might remember. The very first version of DHIS, so-called DHIS1, was implemented on Microsoft Access, for example, for those of us who know Microsoft Access. But you cannot have a system implemented on that technology that works at a small scale in South Africa at the time and expect that you're going to deploy it at the sort of global scale that DHIS enjoys today. So I think that's one. The second part is sustainability, right? And I know many of us think about sustainability in terms of finance, and that's important. That's why, a couple of us have already spoken about innovative financing model, the kind of co-financing that Living Good is doing with Kisumu, for example. But I think the other part of sustainability that we sometimes neglect is systems are sustainable when they create value, right? M-Pesa, for example, if it is switched off today, we are all going to complain very loudly, and we are not going to be happy. And the reason that is that it actually creates value for us. So much so that even when sometimes we complain about charges and we say these guys are overcharging us and they should be charging us less, do we stop using it? No, because what is the alternative? Before there was M-Pesa and you wanted to send your grandmother or mother money in the village, what did you do? You went and you found the one matatu that goes to your village, and you had to speak to those guys, and sometimes your money would get lost in the process. So I think a big part of sustainability also is that these systems must create value, and they must create value across all constituencies of users. And I say that because, and I'm happy that somebody talked about human-centered design earlier. It's important to make sure that you're addressing the needs of all your user constituencies. Sometimes because we are the ones who come to conferences like this and have these discussions, when we are designing these systems, we think a lot about data, and that's important. We want these systems to collect data to support decision making. But do we think about the user experience for the CHP themselves, for example, right? We have to deploy, we have to create and deploy such good systems that every user group is actually happy to use that system. That if you took it away from them today, they would actually complain and they would be demanding for it. And then the other piece, and I think it was Rita who said, technology is supposed to create efficiencies and save you money. Now, often you hear people say things like, this is expensive, so it's very difficult to sustain it. But in a sense, that's also part of the problem. Like you ought to think about how do we develop this technology in a way that it creates efficiencies that actually make it cheaper than the manual system. If you do it that way, then you find that the question of sustainability becomes easier to address. And then, of course, the other piece is, co-creation. So that, again, going back to the same point, that you make sure you're addressing the needs of everybody that you expect to be using that technology. And I think the other thing also is capacity. This was spoken about earlier in the morning. From my experience, what I have seen is when we deploy new digital health interventions, we do train users typically because we almost intuitively realize that that's important. But are we investing in continually training and building the capacity of those users? We are adding new features, new people are coming on board. People are people, so they are also sometimes getting forgetful. So it's important to explore innovative ways for providing that continuous capacity building. And even at Living Goods, for example, some of the techniques that we have explored and we've seen they bear value is e-learning, for instance, so that the individuals or the users of these systems actually have the capability to continue improving their knowledge, building their capacity in a way that's directly accessible to them, but that is also cheap enough to be sustainable in the long haul. So yeah, those are a couple of ideas I would like to share. Thanks.
Thank you for that, Gitahi. And I can see that scalability really needs to put into consideration each and every user within the ecosystem. And for Roy, let's get a bit specific. with an innovation. So, telemedicine is one of the key innovations in the digital health ecosystem. So, from your experience, how can digital health help reduce the cost to serve patients and our population management system?
Yeah, thanks Hilda. I think that's a good question. Before I dive into it, just for the benefit of everyone, I lead a telemedicine company called HealthX, and how we are structured is we run a call center in Nairobi. We're a Kenyan company, and this call center has GPs, nutritionists, psychologists. From there, we have served so far patients in 40 out of the 47 counties of Kenya, and we have a technology stack which allows people to reach us, regardless of wherever you are, 24/7. Our focus is on the uninsured and underinsured. So this conversation is very relevant to us because we are focusing on rural communities basically. How people reach us is a couple of ways. Number one, mobile app, meaning you have a smartphone, you download the app, you do a video call or a voice call. However, we know smartphone penetration is very low. In Kenya, there are about 65 million phones. Out of that, 50%, almost 50% is smart, the others are feature phones. The other key thing you need to know is internet penetration is low, or even where there's internet, guys cannot afford to buy that internet. So 80% of our consumers, 80%, which is a big number, use toll-free, meaning they just call a number and they can speak to a doctor without needing airtime, without needing a smartphone. The other key technology item which enables people in rural areas to access our services is what you call a virtual clinic. A virtual clinic is a screen designed in a booth for privacy where someone can walk in and speak to a doctor. In this case, they don't need a phone. There is a nurse manning this virtual clinic who does the triage. There are devices which also empower this process so that if it's blood pressure, if it's temperature, it automatically goes into our electronic medical record system. And then the consult is done by the doctor sitting at our call center. So this is how we work. One of the big areas we've experienced so far with tremendous growth is mental health. There's a big need of mental health services across this country. The statistics are 1 in 4. So you can imagine on this panel, if it's 1 in 4, there are about 2 who have a mental health issue. So that's the general statistic for Kenya. And you can imagine the number of calls we're getting, and the busiest time is between 5 and 9 p.m. So having said that, we have actually managed to deploy a solution in rural communities. And also, to Eugene's point, we are serving also people living with disability. In our call center, we have doctors who speak sign language. We have actually gone ahead to hire doctors who speak vernacular on demand. For example, we did a project in Nandi, we had to hire Kalenjin-speaking doctors. Right now, we have a big project in Murang'a County. We have doctors who speak the language. So what we've done, for example, in Murang'a County is we've gone to Mathioya sub-county, the remotest areas where they have an infrastructure in the form of dispensaries, they have a nurse, but they don't have doctors. So how we come in is we come in and put the virtual clinics. I wish I could show you images where now the virtual clinic is there, and allow me to use the word VC. The nurse will then do triage, and then they speak to our doctor virtually. Lab services are there, pharmacy is there. The persons we are serving right now, we're serving about 2,300 NCD patients on schedule. So we schedule them, they come for appointments, and then they consult with our doctor. Then they're booked for the next appointment. What we are doing now, we're saying you don't even need to come to the facility. This is after assessing them, and we know we can map them based on a risk matrix. And for those who are a bit well, they can actually get their follow-up visits from home. For those who need prescription refills, the medication can be delivered by motorbike. So you think about counties, what it means then, I saw there was a GIS map of facilities, and they were saying they're building now facilities for every 2 kilometers. We don't need to do that. It's a waste of capex. What we need to do is to say, can we put virtual clinics, for example, in schools? There are schools everywhere. There are chiefs camps everywhere. And make these hubs. Then we integrate these hubs into the primary care networks. We should then have a referral system which goes both to level 3, level 4, level 5, based on a need basis, with both public and private players. Then SHIF, we're happy now with the Digital Health Act, It allows for digital health service providers such as ourselves to be able to make claims on shift, which NHIF was not allowing. So if we can integrate all this into the PCN, we can be able to improve the health outcomes, Hilda, to your question, and provide early intervention. Now think about providing this care at scale. When you're providing this care to millions of people and the kind of data you're collecting, then we can now do predictive analytics. We can do early warning systems. We can deploy AI and machine learning, which we're already doing. With time in the future, I see a chance where people in Kisumu County can be able to even interact with the chatbot in Doluo. One of the challenges we face in Busia County is people are getting SMSs, but they don't understand. We've integrated with the CHPs by giving them our toll-free numbers for our maternal health product or service which we're doing with Living Goods. And the CHPs are able to onboard mothers onto this program, and mothers can call us. In the last 2 weeks, we had a mother calling us because she had successfully delivered a baby. She's in hospital, but she's not trusting the kind of care she's being given at the hospital. So she calls us as a second opinion, asking, I'm being given dawa inakaa hivi, I'm being told to do this. Are you okay with that? So we are the second opinion doctor. So we see huge opportunity under PPP framework by integrating private players into the PCNs, and we'll build a very sustainable model. Thank you.
Thank you for that. Thank you all. I think I'll just quickly summarize so that we can close. Starting within the counties to the end users, creating a policy and regulatory framework that supports standard digitization of community health workers, creating room for innovation so that we can use the existing tools to serve within our population. We have designing systems at scale that serves the needs of all users. And we do have the ability to use specific innovations to reach those that are uninsured and they can access healthcare. So I'd like to thank you all for listening to us, and I'd like to thank the experts within the panel. I believe they've provided us with some insights and some new knowledge that we can take away. So allow us to end the panel here, but if you have any questions, please reach out to us as we sit. Thank you.
All right, wonderful panel. There we go. Once again, tuwapigie makofi. They have done well, yeah? Wow. I'm taking big steps in life, yeah? We thank God for that. Hello, guys. How are you feeling? How is that panel? Very good, yeah? So what you're gonna do, just rise up on your feet, wherever you are, just rise up on your feet. Just rise up. I want you to stretch a little bit, yeah? Yeah, that is your bone making that noise. It's not your name.